Tonight's lecture is Urinary Elimination. That's chapter 31 in your text. Normal urinary elimination rids the body of harmful waste products. If the urinary system is not functioning properly, harmful waste products are going to build up in the blood and become toxic to the body. First thing I'm going to do is do a really brief review of the anatomy and physiology. The urinary system consists of the kidneys, the ureters, the bladder, and the urethra. The kidneys are two bean-shaped, fist-sized, about the size of your fist, organs located lateral to the spinal column. The function of the kidneys is to filter the blood and remove the toxic waste products. From the kidneys, the urine travels through the ureters to the bladder. The bladder is a hollow storage bag, kind of like, think of it like a Glad bag. Its job is to collect fluid. In this case, the fluid is urine. When the bladder is full, the muscles surrounding the bladder contract, the muscles of the urethra relax, and urine is expelled from the body. Picture the bladder like an empty balloon. When you fill the balloon with water and then you squeeze it, the tide opening at the bottom is forced open and the water is drained from the balloon. I was going to bring a balloon filled with water and try a demonstration, but I was afraid I'd spill it all over the studio desk, so I chickened out. And if you look at my little picture, it kind of gives you a better idea of what the urinary tract looks like. Normal urine is 95% water, 5% mineral salts, and nitrogenous waste products. That would be urea, uric acid, and creatinine. As you know, the normal color of urine is straw-colored. The color actually reflects your hydration status. When you're dehydrated, the urine gets darker. When you're a little bit dehydrated, it becomes a darker yellow, and someone who is very dehydrated has amber-colored urine. The clarity means the clearness. If a liquid is clear, you can see through it, like this water. I can see through it, so the water is clear. Normal urine is going to be clear. Cloudy urine contains bacteria, red blood cells, maybe white blood cells, and nitrogenous waste. And that's an indication that a person has an infection. Urine that sits too long at room temperature will also become cloudy. Normal urine has a characteristic aromatic odor. That's a mild odor, and it's very slight. The amount of urine that is normal in an adult is about 1,000 to 3,000 milliliters in 24 hours. The acceptable minimal hourly urine output is 30 milliliters per hour. That's a really important number to remember. You always want to be assessing the person to make sure that they are putting out 30 milliliters per hour of urine. A person should have a balanced intake and output. By this I mean the amount of liquid you take in and the amount of urine you put out should be within 300 to 500 milliliters of each other in 24 hours. So if I drink 2,000 milliliters in 24 hours, I should urinate from 1,500 to 2,500 milliliters in 24 hours. The pH. The normal pH of urine is 4.5 to 8. Remember, the lower the number, the more acidic. Your diet does influence the pH. High dairy makes your urine more alkaline. Protein will make it more acidic, as will some fruit juices. The other thing I want to talk about is specific gravity. Normal specific gravity is 1.005 to 1.003. Specific gravity is how concentrated or how diluted your urine is. If you have low specific gravity, it means there's more water in the urine and the urine is more diluted. So high specific gravity means the urine is less water and more concentrated. Normal urine has no bacteria, no glucose, no ketones, no nitrates. It may have microscopic amounts of red blood cells, white blood cells. And you can look at table 31.1 on page 668. And I remember we did go over that with Mrs. Savage on the adaptive about a week ago. A normal voiding pattern. A normal voiding pattern means an adult would usually urinate about 4 to 6 times a day, usually sleeps throughout the night and does not have to urinate. However, the frequency and volume, by volume I mean the amount of milliliters, of urine output is going to be directly related to the fluid intake. So if I drink more water, I'm going to urinate more often. And if I drink late at night or later in the day, I may wake up in the middle of the night and need to use the bathroom. Since I called this the normal voiding pattern, I want to mention that another word for urination is voiding. And the older word, and you hear it still once in a while, is micturation. A urinary assessment. First of all, you want to look at the color. Remember, the color of the urine is going to reflect the hydration status of the person. If you think the person's dehydrated, you know from physical assessment they're going to check for tenting. The clarity of the urine, if the urine is cloudy, it could indicate infection or other urinary tract disorders. Look for edema. Look at the hands, the face, the legs, the feet. Edema is going to indicate fluid retention, so you'd want to check for pitting. In other words, the person is retaining fluid. Maybe it isn't being urinated properly or filtered through the kidneys. Daily weights. Daily weights, your weight is an indication of how much fluid you're retaining. If I think you're retaining fluid, I'm going to weigh you daily. And any weight gain of 2 to 3 pounds is extremely significant. Urinary frequency. If you're urinating more frequently than normal, it could indicate that you have a UTI, which is a urinary tract infection, or it could be a sign of diabetes. You want to check with the person and see if they have any burning pain or difficulty when they're urinating. The medical term for difficult urination is dysuria. Any of those things could indicate a UTI or inflammation. Ask the person if they have any incontinence. Check the odor of the urine. If you notice any uncharacteristic odor to the urine, it could be an indication of a disease. For example, a fruity sweet odor to the urine could indicate the person is diabetic. If it had a foul odor, it may indicate infection. And then, of course, you always want to check and find out if the patient has a catheter or if they catheterize themselves frequently. To diagnose urinary tract problems, the first thing we do is a urinary specimen. Urinalysis is called a UA, so urinalysis, urine, and the A for analysis. A urinalysis is done to check for kidney stones, the medical term being renal calculi, UTIs, malignancies, and kidney disease. As nurses, you instruct the patient to void, micturate, or urinate into a specimen cup. Make sure to label the cup and transport it to the lab. If the specimen cannot be transported to the lab right away, it's stored in a refrigerator. Because urine that's left standing for longer than an hour is going to break down and decompensate, and the urinalysis results will be invalid. Then another urinary specimen test we do is called a clean catch urine. If you look on page 684, skill 31.3, it tells you how to do this. The initials for that is CCUA, clean, catch, and UA means urinalysis. Instruct the patient to clean the urinary meatus, that's the opening, with an aseptic wipe. Females clean from front to back. Dispose of each wipe after one pass. If you go back over an area, you've contaminated it. For a man, they should clean in a circular motion from the meatus outward. Instruct the patient to start to urinate into the toilet and then stop the stream. This initial urination removes the contamination from the skin and the opening of the urethra, so the specimen will not be contaminated. Then the patient voids into the specimen cup, as we did with the urinalysis. The specimen cup is labeled and brought to the lab. We also do a test known as a urine culture and sensitivity. The culture is going to identify the bacteria that's present in the urine, and the sensitivity means that it identifies the antibiotic the bacteria will be sensitive to. So sensitivity means you find the antibiotic that is going to destroy the bacteria. Another thing we do is what's known as a timed urinary collection. Usually it's a 24-hour urine. A 24-hour urine evaluates the kidney functioning by basically measuring the amount of protein that a person passes in 24 hours. So, a large container is kept on ice in the patient's bathroom. The reason we put it on ice is to keep the urine from decomposing. Remember, urine left standing at room temperature for over an hour will decompose and not be good and valid for the testing. You have the patient void, and then you discard this first voiding. As soon as that happens, the 24-hour collection time begins. The date and time that the collection starts and the date and time that it ends is going to be clearly posted on the collection bottle, probably signs in the room. For example, I start the urine collection on April 18th at 8 a.m. I'm going to end it exactly at 8 a.m. on April 19th. Every drop of urine must be collected from the point of the first sample till the very last. So every drop of urine for the next 24 hours has to be checked. If a patient has a catheter, a new drainage bag should be attached, and that should be put on ice. If any urine is discarded during the 24-hour period, the test is invalid It must be stopped and restarted. So if at 7 a.m. on April 19th, a specimen is discarded, I have to throw the whole bottle out that I've collected and start over again from that point. Exactly 24 hours after the collection begins, ask the patient to void one more time if they can and add this urine to the collection container. Then make sure it's labeled and get that to the lab. There's also a thing we do that's called reagent testing. Commonly, you call that dipsticks. These things obtain immediate results. If you look at page 668, figure 31.2, you can see a picture of that. You take the stick and dip it into the urine, tap off the excess urine, and the strip is going to change color, which is going to indicate the results. You look at the bottle that they came in, and there'll be a color index or a comparative chart. So you take your dipstick and compare that to what's on the chart, and this will give you your results. It can indicate protein, ketones, glucose, bilirubins. Those are the things we can check with. If we do get positive results, probably further testing will be done. Another thing that we can do is strain the urine. The urine is strained to look for renal calculi or kidney stones. So you instruct the patient to void into a specimen pan. That's what we call a hat, a specimen hat. The specimen pan is pretty much shaped like a nurse's cap, which is why we call it a hat. The hat is placed under the toilet seat. It's really important to instruct the patient not to put toilet paper into the hat. That's going to contaminate the specimen. After the patient voids, the urine is poured through a strainer. If a stone is collected in the strainer, it is sent to the lab. If you look at figure 31.3 on page 668, you can see a picture of a specimen pan or a specimen hat and a strainer. Another thing that nurses do is bladder scans. You can see a picture of that on page 670, and also it's a skill, which is 31.4 on page 635. A bladder scan is an ultrasound that measures the amount of residual urine in the bladder after voiding. The amount of residual urine, residual meaning it just still resides in the bladder, it didn't come out. The amount of residual urine that remains in the bladder after a person voids should be no more than 100 milliliters. So it should be 100 milliliters or less. If the residual urine is more than 100 milliliters, the doctor may order a catheter. Blood work, there are some blood work that we do for the kidneys and to see if the person is having any urinary tract problems. The big one is BUN, blood urea nitrogen. It can, if it's high, it can indicate an infection or renal impairment. We'll talk more about that later in med-surg. Intake and output, I want to mention briefly. We've already gone over it to some extent. Intake is the amount of fluid going into the body. That could be, and it's liquid, so it could be by mouth, by feeding tube, or by IV. The output is the amount of fluid coming out of the body. That could be by voiding, through a catheter, drainage tubes, wounds, vomit, liquid stool, etc. And you already talked in adaptive about insensible loss, but that's a fluid that you can't measure from expiration when you breathe a little fluid out when you breathe out, and from perspiration. The average normal and sensible loss is about 200 milliliters a day. When measuring intake and output, make sure to take into account that the intake and output should be balanced. Remember, between 300 to 500 milliliters of each other in 24 hours. If the intake is significantly more than the output, it can mean fluid overload. And if the output is more than the intake, it can mean dehydration and fluid deficiency. If a patient does not have a catheter, a specimen hat is placed under the rim of the toilet for females. Males are going to use a urinal, and that way we can measure the urine. It's always measured in a graduate cylinder. If the patient has an indwelling catheter, the urine will drain into a urinary drainage bag. I'll probably mention this again, but if you do have a urinary drainage bag, don't go by the measurements on the bag. They can be very inaccurate. You should always have a container with measurements on it, which is called a graduate cylinder. Next, I want to talk about catheters. A urinary catheter is a tube that's going to be passed through the urethra and into the bladder to drain urine, or it can also be used to instill medication. There's several different types of catheters. There's a straight catheter. A straight catheter has one lumen, that means one opening at the end of the tube. It's used to drain residual urine or to obtain a urine specimen. Patients can be self-taught to catheterize at home to drain residual urine, or it's also used for somebody who has what's known as a urogenic bladder. That's when the nerves of the bladder do not function. It would probably be a person that has some paralysis, so they don't have the nerve function in their bladder anymore. A straight catheter goes in and then comes out immediately after draining the urine or obtaining specimens. So a straight catheter is only used for that particular time and then removed. The second type of catheter is an indwelling catheter. We call these Foley catheters. That, I guess Dr. Foley probably invented them or something, but they're not all Foley catheters. That's just the name we call them. They're technically indwelling catheters. They have a double lumen, so they have the opening that drains urine continuously, just like the straight cath. And they have another lumen that's a port where you can insert a syringe and blow up a balloon, and that balloon is going to hold the catheter in place. There's a picture of that on page 673, and you can see in the outline a picture of it as well with the balloon blown up. An indwelling catheter is used for acute urinary retention. If a person has a urinary obstruction, it's very helpful when you're trying to obtain accurate output. It helps prevent skin breakdown when a person is incontinent, and it's often used to prevent surgical complications after abdominal surgery or urinary tract surgery. And they also put catheters in as an end-to-life comfort measure. Condom Catheter has, if you look at the picture, has a curved tip. These catheters are used in male patients that have enlarged prostate glands, because the curvature on it, it can pass more easily through the enlarged prostate. A three-way catheter, so we already talked about the indwelling catheter having 2 lumens. A three-way catheter is a triple lumen catheter. It's also known as an Alcock catheter. Anyway, 1 lumen drains the urine. The second lumen blows up the balloon, and the third lumen is used to instill sterile irrigating solution into the bladder to remove clots and tissue. A three-way catheter is used for only one purpose, and that's to irrigate the male bladder after prostate surgery, which is known as transurethral resection of the prostate, or TURP, T-U-R-P. The continuous bladder irrigation helps prevent blood clots and tissue from obstructing the flow of urine from the bladder. There's a picture of that on page 673, figure 31.8. So what we do is we take a bag of sterile irrigating solution and hang it on an IV pole, and at a slow, continuous rate, the irrigating solution is going to pass into the bladder through the tubing, which is going to be connected to the third lumen of the catheter to flush out the tissue and blood clots. You want to assess the patient closely and carefully, frequently. If the urine in the drainage bag becomes red, it's an indication of blood, or clots are noticeable in the drainage bag or tubing. The rate of the flow of the irrigation solution is increased. You don't want the drainage to be red. What you're looking for is light pink drainage. Assess the drainage bag frequently and make sure the urine is draining. You've got to remember that a blood clot could clog the drainage lumen of the catheter. So the catheter is blocked, the urine can't get through to drain into the drainage bag, but the irrigation fluid can still get in. So the irrigation fluid continues to fill up the bladder. The urine is also filling up the bladder, and there's no way for any of this to get out. The bladder is going to become fuller and fuller, and it could potentially rupture should there be a clot there. So it's very important to notice this and to fix it ASAP. When this happens, the catheter may need to be irrigated manually. So we would get an irrigating kit, use sterile solution in a large bulb syringe. When you're measuring the output for when somebody has continuous bladder irrigation, you have to remember to get an accurate output. You have to subtract the amount of irrigating solution instilled from the amount of fluid in the drainage bag. So if I put in 500 milliliters of irrigation solution, and I go to empty the bag and there's 1,000 milliliters of fluid, I would subtract 1,000 from 500, which would mean 500 mLs of what I've collected is urine. The other 500 is irrigating solution. And this is skill 31.8, page 691 in your book. Another type of catheter is a suprapubic catheter. You can see a picture of that on page 674. When a person has a suprapubic catheter inserted, a small incision is made above the pubic bone, and the MD passes the catheter directly into the bladder They're bypassing the opening the urethra and the ureters. The suprapubic cath is used if a catheter cannot be inserted because of trauma or surgery to the ureter, or urethra, I mean. And then a condom catheter, they also call it a Texas catheter. I'm not sure why. I guess maybe they invented it in Texas. I don't know. But a condom catheter looks like a condom with a drainage tube attached. The drainage tube is about 2 inches in diameter. And there's a connector on the end that it's going to attach to a drainage bag. The urine's going to collect in the condom-like sheath and is drained into either the drainage bag or a leg bag that attaches to the person's thigh. The condom catheter is an external catheter because it does not enter the urethra. To put a condom cath on, it is rolled onto the penis and held in place with double-sided adhesive tape. It's important that the adhesive strip is applied in a spiral fashion. Otherwise, if it's put on in a circular fashion, it could interfere with the circulation to the penis. It would be like a tourniquet. Always make sure that the foreskin is in place in an uncircumcised male. The advantage of a condom catheter is there's less chance of a UTI since it is not an invasive procedure. The disadvantages are a skin breakdown because the urine is going to pool in the condom-like sheath and contact the skin of the penis. Constriction of the penis if the tape's put on incorrectly. And, of course, a lot of times it falls off and doesn't stay on if it isn't put on properly, which is a huge disadvantage. Condom caths are used for males who are incontinent of urine, and you want to avoid the risk of a UTI. Putting on a condom catheter is skill 31-9 on page 691. The next thing we're going to talk about is taking care of the catheter. Inserting a catheter, which is skill 31-5 on page 686 to 689. Obviously, this is a skill that you need to learn in lab. It's not a skill that your family members would probably let you practice on them. So we really need to get back to lab to practice this. It is a sterile procedure, and sterile technique needs to be carefully and strictly followed. Catheters come in pre-packaged kits that contain all of the supplies you need. As I said, strict sterile technique must be followed in order to prevent infectious microorganisms from entering the urinary tract. Breaks in sterile technique when you insert a catheter are very likely to result in a UTI. Insurance companies are not required to pay for any UTI that is secondary to a urinary catheter that's been inserted in the hospital. So you can see for many, many reasons why it is imperative that strict sterile technique be followed. Before you catheterize a person, check and make sure they don't have any allergies. Catheters are often made of latex. If a person has a latex allergy, you're going to make sure that you have a silicone catheter. The patient may also be allergic to the betadine swabs. Betadine is what we use to clean the person's perineal area, and betadine is iodine-based. Many people are allergic to iodine. If a patient is allergic to betadine, you need to obtain a non-iodine-based cleaning agent. Catheters come in many sizes. The larger the number, the larger the catheter. The diameter is designated in what is known as French, capital FR units. The smaller sizes are pediatric. For example, a 6 French to a 10 French catheter may be for a pediatric patient. People who have had indwelling catheters for many years generally need larger diameter catheters because of loss of muscle tone. They may have a 22 French or a 24 French. Catheters also come in different lengths, and the inflatable balloons range from 5 milliliters to 30 milliliters. In general, the larger the diameter of the catheter, the larger the balloon. The standard catheter in a cath kit is probably a 14 French, 40 centimeter length with a 10 milliliter balloon. You don't need to memorize any of that. I just was trying to give you an idea so you could visualize the different catheters. The urinary drainage bag. You want to empty that at least every 8 hours, PRN if it's full, and if it gets to be a 3/4 full, probably a good idea to empty it. Make sure you do not touch the drainage spout to any surfaces when you're emptying the bag. After you drain the bag, wipe the drainage spout with an alcohol swab before you close it. Make sure to clamp the drainage spout when you were done. I can't tell you how many times people have gone back into a room after emptying a catheter and found urine on the floor because the person that drained the bag forgot to clamp the clamp. Always use a graduated container when emptying the bag. The measurements on the bag do not give an accurate reading. Keep the drainage bag below the level of the bladder. Urine drains by gravity. What do you think would happen if I had the drainage bag higher than the bladder? What's going to happen is the urine's going to reflux, which means to backflow into the bladder, which is very uncomfortable and can lead to a UTI. The tubing should be free of kinks and coils. Always assess the patient and make sure the tubing is patent. The person could be laying on the tubing. The tubing could be kinked or twisted. Any kinks, coils, or pressure on the tubing are going to obstruct the flow of urine, which again can cause reflux. Always hang the drainage bag on a movable part of the bed. By that I mean a part of the bed that moves up and down when you move the bed up and down. So if the bed goes up, the drainage bag goes up. Bed goes down, the drainage bag goes down. Do not hang the drainage bag on a side rail, because then when the side rail is raised, the bag will be above the bladder. Do not share the measuring devices, the graduated cylinders, on other patients. Keep one graduate cylinder per client. Sharing graduate containers can lead to cross-infection. Everybody should have their own and rinse it thoroughly after you use it. When you go to empty the drainage bag, place a paper towel on the floor before you put the graduate cylinder down. That avoids contamination from those microorganisms harbored on the floor. The drainage bag should never touch the floor. Again, the floor is contaminated. And document and record all urinary output. To care for the catheter, you want to always provide peri-care to the person. Clean the catheter with a clean washcloth and clean water. Hold the catheter in your gloved hand to prevent friction on the tubing, and clean in downward strokes starting at the site of insertion. So start up high where the catheter goes into the urethra. Don't ever go back up once a section has been cleaned. Upward stroke could move microorganisms from the tubing back into the bladder. A cath secure. The catheter is going to be secured to the patient's thigh with a leg strap. If you think back when we did that Zoom meeting for adaptive, Mrs. Savage had a cath secure that she used on Daniel the tiger's G-tube. I wrote David, but I'm pretty sure now that I think back, the tiger was named Daniel. Using a cath secure is going to prevent tugging on the catheter. And if the person is ambulating, the cath secure is going to help prevent the person from stepping on the tubing. Imagine that stepping on the tubing could pull the catheter out of the bladder. And that really has to hurt when somebody pulls an indwelling catheter, balloon and all, out of their bladder. Discontinuing a catheter, that's skill 1311 on page 693. Position your patient supine and put a towel or a chucks under them, or an incontinence pad. Attach a syringe to the lumen, the same place that you attach it to blow the balloon up, and remove the same amount of water that was put in to inflate the balloon. Usually it's 10 milliliters. Allow all of the water from the catheter balloon to fill the syringe. Then have the patient take a deep breath and gently and quickly slide the catheter out of the bladder. 8 hours after the catheter is removed, the patient has to have voided. If they have not voided, or if they've only voided a small amount, 240 milliliters or less, a bladder scan is going to be done to check for residual urine. You want to let the doctor know the results, and he or she may order a straight cath, or they may even advise you to reinsert the Foley catheter, depending on the amount of residual urine that's left. You can also obtain a urine specimen from a catheter. That's skill 31-6 on page 689. What you want to do is clamp the tubing below the level of the port on the tubing that you're going to use to withdraw the specimen. This way you're sure you're going to get new urine, fresh urine. You don't want to have old urine that's remained in the tubing when you do a specimen. Clean the port with alcohol and allow it to dry. And then insert a blunt needle syringe into the port and withdraw a little bit of urine. You only need about 5 or 8 milliliters. You want to pull back very slowly and steadily. Once you get your urine into the syringe, you empty it into the specimen cup, label it, and take it to the lab. Never, and you see this all the time, but don't be that nurse that does it. Never obtain the specimen by disconnecting the catheter from the tubing. What do you think's happened whenever you do this? You're setting up a terrible potential for infection because you've opened up a door or a portal of entry. Never obtain a specimen from the drainage bag. Most likely this could be old, stale urine, and it wouldn't be an accurate test. When you're done getting your specimen, you put it in the cup. Make sure to unclamp the tubing so that the urine can drain freely. Again, if you forget to unclamp it, you're going to have the urine refluxing into the bladder, and the bladder could become fuller and fuller and possibly rupture. And that's basically it for catheters. These are not skills you're going to really learn from reading about them in the book. I'm hoping you just kind of know the basic principles of it. And when we get back to lab, we will definitely do all of these things. You will have a catheter kit that you can practice with, and then we will check you off on the skill. Another skill is to assist people with bedpans and urinals. It's very important that you respond to call lights in a timely manner. Don't be that nurse, and there's a lot of them. I know people that work as CNAs would probably agree with me, but don't be that nurse who refuses to assist with toileting. The nurse who walks by a room with a light on, or the nurse that goes in, the person's at the end of the hall, the nurse goes in, the patient says they need their urinal, say just a minute, you walk out, you walk all the way back to the desk and find an aide and say, Mr. Smith in room 240 by the window needs a urinal. Don't ever ask somebody to do something you wouldn't do yourself. I mean, there are times when you can't, you're too busy, but don't be that nurse that continuously never helps with toileting. Bedpans, that would be skill 31-2 on page 683. There's two basic types of bedpans, the regular bedpan and the fracture pan. The fracture pan was invented for patients who've had hip or back surgery, but they're also much easier for a person who's very thin or has any back pain when sitting on a regular bedpan to use. Bedpans are not the most comfortable invention that we've ever come up with, and a fracture pan is a little bit more comfortable. Always provide privacy. Make sure the patient has toilet paper. Raise the head of the bed after you position the patient on a bedpan. You don't lay down on the toilet, so you don't go to the bathroom when you're laying down. It's pretty impossible. So make sure the person is sitting up as naturally as you can get them, as if they were sitting on a toilet. Remove the bedpan in a timely manner when the patient is done. Don't leave that poor person sitting on the uncomfortable bedpan a moment longer than they have to. I know if it was me, I'd probably find a way to get off of that bedpan, and then it would be a bigger mess than if you'd have come in when I rang my bell. Empty the bedpan promptly. Don't leave urine and feces sitting around. It's a big breeding ground for infection, and the unpleasant odor is disturbing to the patient, and it's embarrassing. Clean the bedpan and store it in the bedside table. Assist the patient with peri-care and with hand hygiene. I remember one time we had students and we were in the room of a patient, and you could tell smell this horrible odor of urine. And it was old urine. You could tell it had been sitting a while because it had a really strong ammonia smell. And looking all over, couldn't find anything. Changed the sheets, and then we opened the top drawer of the bedside table, and somebody had stuck a fracture pan full of urine in the drawer and forgotten it. So I always think about that when I think about how important it is to get rid of the contents of the bedpan properly and make sure that you put it away in the right place. Urinals. Urinals are used for male clients. That would be skill 31.1 on page 683. Male patients have difficulty voiding when they're laying down or sitting. Unless contraindicated, assist the man to a standing position. Empty urinals promptly. You often find urinals hanging on the side rails full of urine. You want to empty that and clean it and return it to the patient empty. Keep the urinals within reach. Commonly, you see them hanging on the side rails, which is fine. The man can reach it easily when he needs to urinate. Then you also assist him with peri-care and offer hand hygiene. We'll also practice the skill of assisting with bedpans and urinals when we get back to lab. The next thing I want to talk about are alterations in urinary function. Problems with urinary function can happen in any part of the urinary tract, the kidneys, the ureters, the bladder, or the urethra. Urinary retention. Urinary retention happens when the person cannot empty their bladder completely. In some cases, the patient may not be able to empty their bladder at all. The kidneys are functioning normally in this case. The problem is the bladder. There are many reasons why urinary retention happens. It could be an obstruction caused by a tumor. It could be a kidney stone blocking the outlet. It could be an enlarged prostate. It could be an enlarged uterus due to pregnancy, or it could be scar tissue. It could also be due to a UTI, postoperative complications, nerve damage, or medication. So the bladder fills up. The person urinates, but not all of the urine is eliminated. The problem is that the urine that remains in the bladder can reflux or flow backward into the kidney. If this happens and if this problem continues, it can lead to kidney atrophy, which is shrinkage of the kidney, and chronic renal failure. Residual urine is the term we use for the urine left in the bladder after a person voids. The amount of urine left in the bladder after voiding, remember, should be no more than 100 milliliters. We check for residual urine by palpating the bladder to see if it's distended, so that does the urine feel enlarged, maybe hard. A bladder scan can be done to estimate the volume or amount of urine remaining in the bladder, and the doctor may order straight catheterization to remove the residual urine. If a person has chronic urinary retention, they're taught to self-catheterize after every void. The amount of residual the amount of residual urine should be documented after every voiding. Even the person at home should be taught to do this. The term nocturia means to urinate during the sleeping hours. If a person occasionally wakes up to void, it is probably because of drinking large amounts of fluid in the evening before they went to bed. But frequent, persistent nocturia is probably due to an underlying disease, like heart failure, diabetes, a UTI, an enlarged prostate, or maybe kidney failure. Urinary incontinence is my second alteration in urinary function. There's many different kinds of urinary incontinence, but basically the term means the inability to control your urination. The first type of incontinence is known as stress incontinence. That's the involuntary release or loss of small amounts of urine. By small, I mean under 50 milliliters. Stress incontinence is brought on by activities such as laughing, sneezing, coughing, exercising, and lifting. It's due to weakened pelvic floor muscles, and it's more common in females after childbirth. The next type of incontinence is urge incontinence. That's the strong urge to void, even though the bladder isn't full. It's what we call an overactive bladder. And there was a commercial several years ago about medication for overactive bladder, and what they would say, gotta go right now. The person cannot wait to get to the bathroom. They rush until they find a bathroom, and they have to find a bathroom frequently. In this case, the detrusor muscle, that's the muscle that surrounds the bladder. It's not behaving itself. It contracts when it shouldn't. It will contract even when the bladder isn't empty. When it contracts, it causes the bladder to empty, even though it isn't full. Third type of incontinence is reflux incontinence. Reflux incontinence, I'm just going to mention, it has nothing to do with the urinary tract problem. It's due to a central nervous system disorder, such as paralysis. This person doesn't know their bladder is full, and they have no urge to void. The bladder is going to fill to capacity, and it's going to empty. But the person is totally aware of the whole process. Again, this is neurological, not urological. Next type is overflow incontinence. Urine is going to leak around an obstruction. That would be like an enlarged prostate. When the person feels the urge to urinate, only small amounts are expelled because of the obstruction. The bladder fills but cannot completely empty because of the obstruction, and it's going to eventually overflow, which will make the person incontinent. Functional incontinence is the ability of a normally continent person to, the inability of a normally continent person to reach the toilet or bedpan in time to prevent the unintentional loss of urine. There is nothing wrong with the systems. The neurological system functions fine, the urological system functions fine. The person has other disabilities like trouble with mobility that prevents them from dependently getting out of bed and going to the bathroom. The staff must assist the person with getting to the bathroom or the bedpan, or they're going to be incontinent. This is probably the worst type of incontinence that you could have, because we as nurses should never let this happen. The functionally incontinent patient is aware of the need to urinate but cannot get to the bathroom without assistance. They need the assistance of the staff or they'll be incontinent. So it's doubly embarrassing for them. They know they need to go to the bathroom. They can't get there. And it's humiliating. Sometimes people are too busy and they can't get to the person. That's true. But if it's one of those cases where we're ignoring the call light, shame on us. And there's also mixed incontinence, which means that you could have two types of incontinence at the same time. Usually it's stress and urge incontinence that like to partner up. Incontinence can be transient. Oftentimes it's short-term because a person has a urinary tract infection, or it could be due to medication a person is taking. For example, if you're on a diuretic like Lasix, it can make you have temporary incontinence. Another term of incontinence is enuresis. Enuresis is the involuntary urination a child has after the ages of 5 to 6. It would be called primary enuresis if the child was never toilet trained, which is uncommon if the child is 5 or 6 years old. Or it can be secondary enuresis if control is lost after the child had established toilet training. Usually secondary enuresis is stress-related. If, for example, your parents get a divorce, suddenly you're 6 years old, you're an only child, and suddenly there's a new baby in town that's getting a lot of attention with getting those diapers changed. Or it could be secondary to a urinary tract infection or allergies. There's also what's known as nocturnal enuresis, that's bedwetting. It's usually genetic. If a child is a bedwetter, usually one or more parents wet their bed as children. Most children outgrow it. A very small percentage of bedwetting is caused by medical conditions. That would be urinary tract infections, diabetes, urinary obstruction, or neurological conditions. So there are complications of being incontinent. Emotionally, the person feels shame, embarrassment, and they might become socially isolated. If you're incontinent, you may start avoiding social outings. You don't want to go anywhere. You don't want people to know or smell your urine, so you don't go out. Urinary tract infections are another complication of incontinence, and skin breakdown. Medically, treatments would include such things as ditropan and ditrol. Those are medications that inhibit involuntary bladder contractions, catheterization, and there are surgeries, urinary diversion surgeries and things. You don't need to really memorize all of those. I just want you to be aware they exist. First of all, prostate resection, a TURP. The person may be incontinent because of prostate enlargement. There's a thing called a bladder suspension. That's done to lift a bladder that's sagging into its proper position. Usually this is done only for stress incontinence. You see it a lot of times after a person has had multiple childbirth, the bladder sags or prolapses. So what happens is they take a piece of the person's tissue or a mesh and make a little sling under the bladder to support it. There's another procedure called a sacral nerve stimulation. The sacral nerve is located in your back, the lower back, and it controls the stimulation of the bladder and urethral sphincter. So what they do is they take a programmable stimulator, or it's like a little electrode, and they implant it near the sacral nerve, and it generates a localized low current electrical impulse that stimulates the person to urinate normally. So urinary diversion. Urinary diversion, when a person is unable to empty their bladder independently or with a catheter, a surgical procedure may be done to create an alternate route so that urine does not travel through the bladder. Maybe there was a traumatic bladder event. Maybe the bladder had to be removed due to cancer, or it could have been a birth defect. There's a procedure called an ileoconduit. The ureters are attached to a section of the small intestine. That section would be the ileum of the small intestine. A pouch and stoma are created, or an alternate bladder is made out of the small intestine, and the urine will drain continuously from the stoma. The piece of the ileum or the small intestine creates a new bladder, so to speak. A urostomy. A urostomy is urine is diverted into an internal pouch. The same idea, and it's drained through that. There's a newer procedure out called an orthotopic bladder substitution. That's where they take a part of the small intestine and create a new bladder, just like we said in the other procedures. The ureters drain into this piece of the small intestine, the new bladder, and then the urethra is attached to the new bladder. So the person can actually void like they would normally through their urethra. There are problems with incontinence with this newer procedure, so the patient may need to learn to self-cath frequently or periodically. You don't need to memorize those. I just want you to kind of have an idea of how they work and how amazing it is that they can actually create a new bladder out of a piece of the small intestine. Nursing care of incontinence. When you care for the incontinent patient, promoting good skin care and nursing care of the incontinent patient. When caring for the incontinent patient, promoting good skin care and preventing skin breakdown is a major nursing responsibility. Always treat the patient with respect and dignity. The nurse's reaction and attitude is very important. Understand the person's reaction and don't take it personally. They may be angry, agitated, or embarrassed. You just remember, think about how awful it would be to have to depend on someone else for your toiletry needs. It's humiliating, and it's a very private, personal function. I even find it like uncomfortable to use a public restroom. I can't imagine having somebody helping me with my toileting. I know for a fact that it's a lot easier to be on the side of the bed that I'm on now. I don't even know how I would react if I were in a facility and incontinent. Skin care. Incontinence leads to skin breakdown and UTIs. Of course, you're always going to be using non-sterile gloves with any of these procedures that I mentioned today. You want to keep the linen clean and wrinkle-free. Remove Depends, incontinence pads, and soil linen as soon as possible. Briefs and Depends. Never call these diapers. The incontinent patient wears briefs when out of bed during the day. The briefs tend to trap moisture and can lead to skin breakdown. Ideally, the brief is going to be checked PRN. If the patient is up all day with the same brief on, that is going to lead to a problem. You need to check and toilet those and change them frequently, If the patient wears briefs while sleeping, it needs to be checked and changed frequently. Basically, you can tell if the brief weighs 10 pounds in the morning, somebody didn't do their job. Always check your facility policy though. Some facilities don't want briefs worn at night because they are not checked enough. Incontinence pads are used. Check again for your facility policy for how many can be used. 1 or 2 is the usual policy. You will go in sometimes and see piles of incontinence pads under the patient. Too many pads on top of each other keeps the bed from getting wet, but the patient's going to be in contact with wrinkle-soaked pads leading to skin breakdown. And a saturated incontinence pad is a sign the patient isn't being monitored. Always clean from the cleanest area to the dirtiest area. Use barrier cream. Moisturizers is ordered. Use powder sparingly, it dries the skin out. Make sure the area is clean, dry, and protected. For someone with occasional incontinence, you want to wash them with warm, soapy water. Make sure you rinse thoroughly and pat dry. If someone's frequently incontinent, if you use soap too often, it's going to remove the natural skin oils, and that's going to contribute to skin breakdown. It's better to use an incontinence cleaning solution, which is very gentle and facilitates easy cleaning. A lot of these cleaners do not even require rinsing, and they provide a moisture barrier. However, you don't often see these because the products are very expensive, and unfortunately facilities can't afford to provide them. Always inspect the skin for redness and breakdown, and note any changes since the last time the patient was incontinent. Report skin breakdown. A wound consult may be needed. Position the patient so they're not lying on areas of redness or skin breakdown. Remember, always reposition the patient every 2 hours and PRN if necessary. Thing we can do to help with incontinence is bladder training. It's also called time training. The object of this is to help the patient develop a regular pattern of using the bathroom or bedpan at the same time throughout the day. In order for this to work, all the staff have to strictly adhere to the plan. It does work better if the person has the cognitive ability to take part in the exercise, but it's somewhat effective even if they do not. The goal is that eventually the patient is going to be trained to urinate at these times, and as the brain is going to send a signal to the bladder, it's time to void. Have the patient, if they're capable of it, keep a diary of the times they are incontinent so that you can determine the best time to toilet them. If the patient can't keep a diary, choose logical times and faithfully follow them. For example, maybe before meals, mid-morning, mid-afternoon, mid-evening, bedtime, etc. You may want to start the training by toileting them every half hour, then increase it to every hour, every 2 hours, and so forth. In general, every 2 hours during the day and every 4 hours at night is a realistic plan when you have a full patient load. It's also important to toilet patients after they consume liquids, eat, and things like that. You can help a person to urinate by simulating the sound of urination by running water, pouring water out of a pitcher, pouring water over the peri area, etc. Before a Foley catheter is removed, especially if it's been in there for a while, bladder training may be ordered. What you do here is the catheter is clamped for a certain length of time. It's increased at regular intervals. For example, at first I may clamp the catheter for 5 minutes every 30 minutes. Then I'm going to clamp it for 10 minutes, etc., until I build it up to a reasonable length of time. Hopefully, this will help restore muscle tone so that when the catheter is removed or discontinued, the patient will have more muscle tone and be able to start controlling their urination. There's also exercises known as Kegel's exercises that help strengthen the pelvic floor muscles and also strengthen the urinary sphincter muscles. The regular practice of doing Kegel's exercises helps reduce urinary incontinence. They're easy to do and nobody knows you're doing them. When you're teaching somebody how to do Kegel's exercises, tell them to lie supine, put their hand on their lower abdomen just to make sure that their abdominal muscles are relaxed. Then instruct them to tighten or contract the pelvic floor muscles. This would stop the flow of urine without tightening the abdominal or thigh muscles. If possible, tell them to hold this contraction for 5 to 10 seconds. Do not tell the person to perform this while they're urinating, because repeatedly doing Kegel's exercises when you're urinating can lead to urinary retention. Once you know how to do these exercises, they can be done anywhere, sitting, standing, playing soccer, whatever you would like. The object is to contract and relax the muscles of the pelvic floor that controls the elimination of urine. If done correctly, you're going to feel your pelvic muscles squeezing your urethra. The exercise should be done 40 to 60 times every day and needs to be done regularly and indefinitely to be effective. Other things we can do to facilitate continence, some of these I've said over and over again, so be patient with me. Answer call lights promptly. If the patient is in a bedpan, have them in the high Fowler's position. Remember, don't lay down on the toilet. A bedside commode may be better, and it is better and more comfortable than sitting on a bedpan, and it's more natural. Make sure there's privacy. It's very difficult to urinate if the nurse is standing just outside the privacy curtain. If they are safe alone, tell them you are leaving and to push the call light when they are done. If a patient is male, make sure the urinal is readily available and empty it as soon as possible. If the patient is male, have them stand unless it's contraindicated. Condom catheters, Foley catheters help facilitate continence. Promote adequate fluid nutrition, 8 to 10 8-ounce glasses of fluid a day, and try to limit the intake of fluid in the evening hours before bed. Reducing caffeine intake helps. Caffeine is a bladder irritant. And briefs and panty liners can also be other measures to help. Charting. Make sure you chart and document everything about their intake and output, their urination, their catheter, anything like that. The last thing I'm going to talk about is urinary tract infections, UTIs. Urinary tract infections are the most common urological disorder. The main cause of a UTI is bacteria. You guys already know this, E. coli, that enters the urinary system from the bowel. Women are more prone to UTIs than men because the female's urethra is so close to the anus. Males with enlarged prostate glands are at higher risk for UTIs than other men, and invasive procedures such as catheterization can introduce bacteria into the urinary tract. Urinary tract infections can affect any portion of the urinary tract, and the infection can spread from one area to another. For example, if I have an infection of my bladder, which is known as cystitis, if I don't get treatment for it, it can travel upwards and cause an infection in my kidneys, known as pyelonephritis. Pyelonephritis can lead to scarring of the kidneys and loss of kidney function. That is why it is important to treat a UTI as soon as possible. There are some things we do that can help it to prevent urinary tract infections. The body has some natural defenses of its own. The pH of the urine is acidic, and that's hostile to the bacteria and kills it. The vaginal secretions are also acidic, so they're going to kill some of the bacteria. And voiding or urinating is going to flush bacteria away. Unfortunately, urine and vaginal secretions become more alkaline when you age, making older adults more susceptible to UTIs. So, what are the signs and symptoms of UTIs? If it's a bladder infection or cystitis, the person may have dysuria, that means difficulty urinating. Nocturia, which means urinating after they've gone to sleep. They have to get up in the night. Hematuria, which is blood in the urine. Pyuria, which is pus in the urine. Lower abdominal pain, incontinence, cloudy urine with a foul smell. Frequency, which means urinating often, and urgency. Urgency being the sudden urge to urinate, even though your bladder isn't full. If these signs progress to pyelonephritis, which means that the infection is moved upward from the bladder to the kidneys, so pyelonephritis being a kidney infection, these are the signs and symptoms that are indicated. This would mean it's probably traveled to your kidney. The patient will have fever and chills, general malaise, that awful feeling you just don't know what's wrong, but you feel awful, nausea and vomiting, and flank pain. Your flank is your lower back, which is where your kidneys are located. In an older adult, UTIs do not present like they are typical as they would in a younger person. So they have a whole different atypical presentation, and this geriatric syndrome can easily be mistaken for dementia when what you're seeing is only temporary delirium secondary to the UTI. So think of the acronym SPICES, which accurately describes the signs and symptoms of a UTI in an older adult. S is sleep disturbances. P means problems eating and feeding. I is incontinence. C is for confusion, behavioral problems and changes, and lethargy. E is evidence of falls. S is skin breakdown. What you usually find is the person is very confused, they're not speaking clearly, they're agitated, when you see that in an older adult or any of these other things I listed in spices, your first thing to do is to get an order for a urinalysis. Talk briefly about catheter-associated UTI. I already mentioned it a little bit. Remember that any catheter-associated infection acquired in the hospital is not going to be reimbursed. Nothing is going to be paid for. The medications, the extra hospital days, the consultations, none of it. Unfortunately, catheter-associated infection is the #1 cause of hospital-acquired infection. Factors that contribute to catheter-associated UTIs: a break in sterile technique during insertion. #2, the longer a catheter remains in place, the greater the risk for infection. #3, bacteria can enter the catheter system through improper technique when emptying the bladder drainage bag. Contamination of the catheter when you provide pericare. Urinary reflux from kinked coil tubing or improper placement of the drainage bag, a drainage bag that's higher than the bladder. Often the person suffering from catheter-associated UTIs is asymptomatic until those systemic symptoms arise. Those are the ones: fever, malaise, nausea, and vomiting. So it's even worse than a normal urinary tract infection. A UTI can be diagnosed with a dipstick or reagent strip that'll detect the presence of bacteria, nitrates, and leukocytes. Leukocytes are just a type of white blood cell. And a midstream clean catch urine specimen. That's going to be done if the dipstick or the reagent strip shows positive results. And the clean catch specimen is the definitive diagnosis. The treatment of a UTI is antibiotics. If it's progressed to pyelonephritis, the patient may be hospitalized and given IV antibiotics. There are urinary analgesics available. Those would be to take care of the pain. Over the counter, you see that. You probably heard of Azo, that's sold over the counter, and Pyridium would be a prescription. You don't need to memorize these. But urinary analgesics are only given for short term. And if you have a patient on them, you need to let them know that the urine is going to turn a distinctive orange color. If a UTI is cath-related, the catheter is removed. Nursing measures to prevent UTIs or treat UTIs: empty the bladder every 3 to 4 hours. In PRN, when you feel the urge, you want to avoid voluntary urinary retention. A lot of people do that. We used to call it nurse's bladder because you're so busy running around on the floor doing all your tasks that you just don't have time to go to the bathroom. When you retain and hold your urine like that, it's going to reflux and pool in your bladder. And when it refluxes and pools, you're going to be partial to a urinary tract infection. Drink plenty of fluids. 64 ounces of uncaffeinated fluid per day is recommended unless you're on a restricted fluid diet. There's controversy about low sugar cranberry juice and cranberry pills, but they are still used in people, and they do help according to patients. Milk products should be avoided. They make the urine more alkaline. I always teach women to clean from the front to the back when they're doing pericare. Bubble baths, hygiene sprays and douches. irritate the urethra and can lead to UTIs. Always wear cotton-lined underwear. Adequate rest, good nutrition, and stress reduction. A person should always void before and after intercourse to flush out bacteria. They should void after taking a bath, because after you take a bath, you've been sitting in that bath water that could have some bacteria in it, so you want to flush the bacteria from the bath water out of your system. And antioxidants help promote an immune response. Berries contain a compound that prevents bacteria from adhering to the wall of the bladder. In your end of your chapter in the book, there is a care plan about urinary tract infection that you could look at. I think it ties in pretty good with what you're doing in clinical this week for your case study, and also with this lecture. So if you look at that care plan and plug it into the one you have, it would be a good way of kind of getting some practice with what to put on those care plans. At the end of this lecture, I did a terminology list. You may want to add to it. I may have forgotten some of the things. Some of the words I tried to break down into their roots, like, for example, hematuria, hema meaning blood, and urea meaning urine, oliguria, olig meaning small, urea meaning urine, and so forth. That is the end of my lecture for the day. I will see you guys next week when we talk about skincare. And have a pleasant week, and I'll see you then. Goodbye.